How this anesthesia is first, on the base of the finger, we put a wrap, band tightly, what is it? What's the meaning of this? To let the novocaine to be absorbed and removed from this particular part of the body slower. To postpone the time of anesthesia. Understand? Good time. After that, we make injection of here it is tight, and we make injection on side, lateral side and medial side. Prick by needle, and inject about 1 to 2 milliliter of novocaine on one side and on another side. That's all. Yes, that's all.
Just
because the nerves run on both sides and innervate all the finger. We prick, we prick this area. We inject novocaine, and anesthesia is reached. That's all. After that, we do the operation.
Where is that?
Yes, after we finish it. Good. Okay, if it is subcutaneous, if it is cutaneous, actually what is cutaneous reflow? When the epidermis and derma are separated. Yeah? We just cut. Here we even anesthesia, we do not need anesthesia. We just cut epidermis, remove the pus, and proceed this area of dermis. If it is subcutaneous, this is bone, this is tendon. Yeah. Subcutaneous. We actually do incision of the skin to reach this abscess, to remove it, and as usual, as any current process is treated, we do the same. Opening of the abscess, removing pus, proceeding the cavity, and draining. That's all. Though there are some rules due to incisions that will be done on fingers. First rule. Incisions are not performed on dorsal or palmar surfaces of fingers. We could not do it here or here. Incisions could be done only on lateral side, or lateral needle on sides. Okay? Why? Because if incision is performed on palmar or dorsal surface, the scarring tissue could make a contraction of the finger, so that this patient will not be able to use it normally, full volume. To prevent this complication, all incision should be done on the sides of the finger. First rule. Second rule: the incision could be done only within phalanges. Within phalanges, like one. If we need more incision, we make one incision or break, second incision. Okay? Why? Because interphalangeal joints are forced or held by lateral ligaments. And if we occasionally, they are situated in the subcutaneous fat, if we occasionally damage these ligaments, after the operation the finger will be like that. careful. It's not cosmetic. Cosmetic is not injury. To prevent this, we do only within the phalanges. Within the phalanges. Well, then, incision should be longitudinal, always longitudinal, not transverse. Longitudinal. For the distal phalanx, the incision could be okay. And one more rule. We usually do 2 incisions on one and another side. If the abscess is here, we should do 2 incisions from this side and from this side. What's the meaning of these 2 incisions? Opening this pass, draining, cleaning it. After that, we could make a drain, like enter a tube from this side and take it out from this side. So that after operation, we could perceive this area a few times without any disturbance to patient. We could inject antiseptic from this end of the tube, perceive this area, and remove. Finally, it will help to recover patient faster. We say the second incision, we say is contour aperture. Contour aperture, opening on opposite side. This is performed just to make the draining more successful. It is not closed. Why is it closed? Of course, it's open here and it's open here. And this part of the tube has openings on sides. Openings. So that the solution injected from this end will flow out here, proceed to this pleural cavity, but then enter tube again and go out. By the way, it also helps us to know, is it okay already, the cavity, it's already clean or no, because like after operation, for 4 or 6 hours or next day, we could do it, and we could see that the fluid that goes out is clean. It has no pus. That means the purulent process has already stopped. Yes, of course. Yes. Yes, of course, with tube. But not for the rest of life. It will last a few days. Of course, it also depends on what below, what is the deepness of this inflammation and so on. Patient's condition as well. But it's normal. Yes, patients walk with tubes. Sometimes with tubes in the abdomen. It's okay. So it's dealing to subcutaneous weight loss, about osteal weight loss. The tactic, surgical tactic, depends on what is the range of injury, of lesion of the bone. If the bone is rough, no, not rough, is damaged so that it could not be recovered. This part of the finger should be amputated. If it has osteomyelitis, but this osteomyelitis could be treated, sometimes we could make a drill into the phalanx and try to treat this osteomyelitis. Anyway, if the phalanx is destroyed completely, so that there is no bony tissue there, this part of finger should be removed, amputated. No, general study. This is the short general study. Tender vaginitis. This could be pain. This is bone. This is tendon. This is on transverse section of the finger. This is bone. This is tendon. This is tendinous sheath. Tendinous sheath that is attached to bone. And for this area, vessels and nerves enter tendon, supplying vessel, supplying tendon. And this is what we call the cavity of tendinous sheath. What's that? Inflammation of tendon causes inflammation of tendinous sheath, right? And pus accumulates in this cavity. What do you think? Will it this pus press onto this cavity? Definitely, yes. It will press. It will also press the vessels that run there. And accumulation of pus in tendinous sheath finally could lead to ischemia and even necrosis of tendon, of some portion of tendon. That's why tendon vaginitis should be immediately operated. Actually, it causes great pain. By the way, any of the types of breed loom causes yes, pain. Patients usually come in time. The procedure is the same. I mean, the tactic is the same technique. We do again the same incisions on site. When we come to the tendinous sheath, we dissect tendinous sheath, remove this part from this side as well. We have to do that. How we do it? We have to do it from, how to say, after making incision on this side, of skin, subcutaneous fat, and so on, then we reach the tendinous sheath. We dissect the tendinous sheath. Then on this side, we dissect skin, come to tendinous sheath, and do not dissect it. We have to pass instrument from this side to that side, so that we could see the tip of the instrument, like this. Yeah. Tip of the instrument. And over this instrument, we should dissect the tendinous sheath on this side. Okay? So now I ask you a question. How we should pass the instrument? Over tendon or under? Over. It's clear, right? Because if under tendon, we will damage this portion of tendinous sheath, and we will cause the ischemia or necrosis of tendon. That's why we do it over tendon, dissect it, and immediately we put a tube, fix it by the instrument, and pass it on this area. That's all. By the way, all these tubes, when the condition improves, when the purulent necrosis stops, the edema disappears, this tube is removed without any anesthesia. Just like that. And pandactylitis. The surgical tactic in pandactylitis is based on the range of damaging of the bone. Because if the bone is damaged, destroyed, then the finger should be removed, amputated, or disarticulated. Should be removed. For example, proximal, middle, and distal phalanges. We could see that the distal phalanx is completely destroyed. On middle phalanx there is osteomyelitis, but it is not destroyed. And in middle phalanx, the subcutaneous fat, tendons are inflamed. In proximal phalanx, also tendons and subcutaneous fat and even joints also could be inflamed. What is our tactic? To remove, to amputate the distal phalanx, and to treat, make incisions, and to treat the middle and proximal phalanges. How to know which phalanx is destroyed, bones of which phalanges are destroyed? X-ray. On X-ray we could see not normal picture of the phalanges. We could see these maybe pieces of bone, or
painful area.
even with no bone.
Is it from painful area?
Huh?
Painful area.
Painful area?
Yeah, from the pain.
Like you mean
The
that
pain
we
are
will
present in the
know that
distal
when
and
this
middle.
is pain, it means it's damaged.
No, pain will be the same for the finger. It will cause really great pain. I mean, not osteomyelitis, even subcutaneous So, for today, the last one. Так, все, for today, that's all. I'll make one more consultation. Maybe on Monday.
Tomorrow model.
Let's do tomorrow.
Okay.
Tomorrow after 5.